Good afternoon, and thanks for the opportunity to talk to you today about the Regional M&M. Now, just before I start, can I have a show of hands of those that are in the room that are working in the metropolitan services in Melbourne? Okay, so of those people, I know there's a few that are actually working with us in this particular initiative when I look around the room, but of those people that have got their hands up, can you keep your hands up, please, if you don't mind? If you have heard about the Regional M&M before today, please put your hand down, otherwise keep your hand up. So it looks like 1, 2, 3, 4 people will be the focus of my presentation this afternoon. Because the rest of you have been living the dream with us for the last 3.5 years. We know that Victoria is a safe place to have a baby. However, every year there are cases where we still experience harm that's preventable. And really identifying preventable harm is a big focus of what we're doing with the Regional M&M initiative. With respect, I want to acknowledge Anisha's presentation, which was very heartfelt, and I'm not going to spend a lot of time on this slide other than to say that some of us, or most of us in this room, worked in maternity services in 2015. And seriously, if you're living under a rock, you might not be aware of what Nisha was talking to earlier on, but I think it is really, really important for us to understand that information drives understanding, but it's about feelings that can actually promote action. And we all know that 2015 was a significant year for all of us in this room for many reasons. I think it's important to understand the why, and really what it is and what it comes down to is investigation and learning when things haven't gone to plan is a really critical part of our work and certainly our commitment to our professionalism as well. So who are we in terms of the Regional M&M? We are a group of multidisciplinary clinicians that are working across 6 regions with a large group of clinicians within that region. And each of the committees that have been established across the state obviously have committee representation that mirrors their clinician groups that are available within that service. And every one of the 31 services that provide maternity care is represented in these committees around the state. So in terms of what we've been doing over the last few years, this is just a bit of an update. There's been 65 meetings to date. And if I thought I was busy the first year, you'll see in the next slides that we have been getting busier despite the fact that the birth numbers in the rural and regional settings have remained stable over the last 3 years. So really what we've been working on is establishing the process to implement this particular strategy, and that has required quite a lot of work, a lot of collaboration between services and certainly between our team and executive teams around the state. We have obviously worked at looking at reviewing a number of cases, and the whole purpose of reviewing those cases is to be able to develop actions and recommendations that can improve practice. There's reports that we generate that obviously go back out to the sector, and clearly we're in a process at the moment of submitting an evaluation that we've been conducting over a period of years. We've developed a procedure manual so that if I get run over by a bus tonight on the way home, I've got something that I can demonstrate that says this is how we've been doing this. And I think it's a really unique piece of work because you don't do these big projects just to sort of basically for no good reason. And there is a lot of learning that could be transferred to other areas of healthcare, which I think is very important. And we are also focusing on an exit strategy and obviously ongoing sustainability. And many of the previous speakers have spoken about that as quite a crucial part of these big projects. Now, if we look at the data from 2016, around about 15,000 births, we had 16 meetings across the 6 regions in that year. And you can see there from those meetings, we generated 65 recommendations that came through statewide from the review of those cases. Numbers stay the same for births in 2017, but we have 24 meetings in that particular year. And again, the case numbers that met criteria that were peer reviewed and then went on for further review at the regional meetings, because there's a process of triage to generate the cases that come from the peer review process into the regional meetings. 139 actions and recommendations, so you can see the number going up. And again in 2018, relatively the same birth numbers, another 24 meetings, case numbers increasing to 731, and of those cases, 171 actions and recommendations. So you can see that even though the births are relatively stable, we are generating quite a lot of actions and recommendations. I just want to share some data with regard to that. So if we look across the triennium, you can see here that there's a trend, and this is quite interesting to us, and we know that we do need to interrogate this data a little further. So this is literally taking the case numbers from across all of the 6 regions that we've been working in. And you can see for stillbirth, we've seen a decrease over the 3 years. For neonatal death, we've seen a decrease, relatively similar in terms of APGAR scores. Fetal growth restriction, and I think the increase in the fetal growth restriction cases that we've been seeing is largely due to the initiative that's been established over the last couple of years and education that's been rolled out around the state. SAM cases, so serious adverse maternal morbidity, we've seen an increase, and again I think that's also an awareness that's been heightened, because when we first started this work there were plenty of people that would say to me, "What do you mean, what's SAM? I'm not sure what you're talking about." And that's obviously any woman that gets admitted to an intensive care department regardless of her gestation and regardless of her diagnosis at that time, or up to 42 days after the birth of that baby. So services, say for example, if you work in Mansfield and you transfer a woman out into the intensive care unit down the road, those services report that woman as a transfer, but the service that actually receives and has the ICU reports that case as a SAM to us and also obviously to COPM as well. So this is interesting when you start to unpack the numbers, and the areas that are shaded there represent areas for us in terms of increased cases, particularly, as I said, in the APGAR criteria. But the one that I think is really very interesting to me, and it does keep me awake sometimes at night, and that is the fact that we're seeing a massive increase in postpartum hemorrhage. Really large, particularly last year, really large postpartum hemorrhages, 4.5 litres, and you really start to think that, gosh, what are we seeing here? What is happening at the bedside? What's happening in terms of some of the decisions? What's underpinning this? And it makes you feel quite curious when you work in that space. This is also on the left-hand column. When we take the actions and recommendations and we table them under a number of categories, because we think that's important to look at what are the themes. What is this data telling us? What are we seeing when we're out there in regional and rural settings? And then what we've done is we've mapped those themes across different cycles for our meetings, because we have quarterly meetings, and at each meeting we're looking at data from the previous 3 months. We think that's really important too, because the timeliness of being able to review cases is very, very important, especially when you think about change management or practice changes. We don't want to be looking at data that's over 12 months of age. We want to be looking at it as close to real time as possible. And again, the consistent theme throughout 2018 has been education and maternal and fetal surveillance. And I'm sure that's not a surprise to many of you in the room here. So clearly there's a process of clinical governance, and I'd have to say when I first started working in this space a few years ago in a previous role that involved education, particularly in rural and regional settings, and sometimes in metro settings as well, you'd use the word governance and you'd have some people that would look at you and think, "Oh, what's that mean?" But certainly as time has evolved, it's really something we do need to think about. We need to ensure that there is a local process. It's not just about coming to a meeting and sitting on a seat and basically not contributing. It's about saying, what does this say to us where we're working? It's about learning from the review of these cases and then translating that through your service, right through from your executive to your bedside. And there's a very wise person in the room that often talks about from the bedside to the boardroom, and they'll remain nameless, but basically I think that's a really important component of our work, is it's about that vision of understanding that are we confident that the right people are getting access to this information and that they know what they need to do about it. So certainly there's an opportunity. We work with a lot of rural regional clinicians and clearly all of the disciplines, but it's a great opportunity to engage rural clinicians not only in the regional M&M process, but we hope that that has a knock-on effect and positively influences how they operate in their local M&M. Because the ideal world for us would be for people to have reviewed their case locally and to have started to sort of analyse the data and have a think about what that means when they bring that case to the regional meeting. We also need to think about, are we engaging the right people with the right expertise or the appropriate expertise? And so, you know, for example, if there's an ambulance transfer, we want to make sure if there's a practice change that relates to that particular transfer, that that's communicated broader and you know, make sure that we engage with each of the disciplines that are involved. Or indeed, if someone has, you know, social issues or mental health issues, that we were not just sitting there and saying, oh, well, you know, we're not sure about the pathway or the process that could have been available for that particular woman at that particular time. There's strategies that we know and we feel very strongly that have helped this process along. It's extremely important to clarify the why. You know, a couple of months ago I was in a rural service and I realised that there were 16 people in this particular in-service, and the in-service was about the work that we were doing in the regional M&M. And it became very apparent to me that a number of the people in that particular group did not know why we are doing this. So it's very hard to engage people and bring them with you, work with them if they don't understand the why. So I think it's very important. I know it sounds pretty basic to some people, but it is an important component of change management. The clinical engagement piece has been really interesting. When we first started this meeting, you know, we know that what we wanted to be able to do is engage very broadly and have an inclusive process for people to attend these meetings. We didn't want to have a situation where it was just a subset group that had this special little meeting and then eventually, you know, some of the outcomes came down the line. So I'm very, very proud to say that we've had really high attendance numbers in a lot of our meetings, right up into about 80, sometimes close to 85, 86 people attending, and that's one region. And I think that's really, really, you know, a testament to the fact that people will not get in the car and come to this particular meeting if they think that what we're doing is not helpful or useful for them. So when you drive or you come to the meeting, obviously the experience is much better than when you're actually on a video conference, but sometimes geographical issues make it difficult for you to be able to attend every meeting in person. It's very important to our team that are facilitating this process with the regional leads that there's local ownership. It's not our meeting, it's not the Royal Women's meeting, and it's not the obstetric peers that I work with. It is the region's meeting, and it's very important to maintain that focus. I think it's important to be able to make sure that the key learnings are obviously identified, and when we select cases, we are definitely looking for what are the cases that actually can demonstrate key learning. Equally, sometimes we present cases where nothing could have been done differently, and then it's about validating the great work that, and sometimes there are cases that just blow your mind, and you sit there and you think, oh my God, how do these people, this must have been so incredible when they had very limited resources and they did a great job, and we have a live mum and a live baby. And I must say that's it's quite humbling, because you sit there and you think this is pretty amazing work. And I also think it's incredibly important to maintain a multidisciplinary focus. When we review a case, we review it with the lens of not just the obstetric changes. We look at the paediatric or neonatal factors. We look at the systems factors. We look at the midwifery change factors. And I think that's really important to not miss the opportunity to engage dialogue from each of the disciplines that are involved in providing maternity care. What can be standardised? Well, again, case criteria. These are things that we've done. We've said, okay, let's try and make some standardised tools, because that's really important in terms of not duplicating resources. The challenges, I would be really foolish to stand up here and say there's been no challenges. There's been a lot of them. And when you undertake large-scale projects, I'm sure there's many people in the room that share these as well. What are we seeing? As I said, we're seeing that clinicians are engaging with this process. We've had strong executive support, and slowly we've seen the cultural change. And if anyone said to me, what's been the hardest thing? The hardest thing in this whole process has been the cultural change to help people to think differently about reviewing M&M cases. I might just move to say that reflective practice is obviously, a strength of this process, and helping people to understand why that's important, and creating an opportunity to be open to another person's perspective is really important as well. We know, as I said, numbers are increasing in terms of the people that are attending. We know that rotating where these meetings are facilitated is very, very important for regional ownership and also for access to the initiative as well. There's a lot of networking that goes on, which is very, very important, and it is really, at the end of the day, about improving practice. People need to understand from a personal level what's in it for them. And I think if you think really seriously, none of us get up in the morning and say, I want to go to work and create havoc. The key messages really are, from a clinical governance point of view, I would ask you to think about your own data where you work. And are you, given what I've just talked to earlier on, particularly in the postpartum hemorrhage criteria, are you across your data? And if not, you probably might need to think about where you can go looking to find that when you leave here today. Thank you.